From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. 2024 has been a year of exciting trials on minimally invasive techniques in intracranial hemorrhage. Here on the podcast, we'll have 2 back-to-back episodes talking about some of these techniques. This month, Chronic Subdural Hematoma, where a minimally invasive strategy called Middle Meningeal Artery Embolization is offering expanded treatment options for select patients. Dr. Chris Kellner is a cerebrovascular neurosurgeon and associate professor of neurosurgery at Mount Sinai. He'll talk about the promise of MMA embolization with Dr. Sarah Nelson, neurointensivist and neurohospitalist at Tufts Medical Center. Here's Sarah.
Thank you so much for joining today, Chris. Really appreciate your time.
Thanks a lot for having me, Sarah.
So first of all, to level set for our audience, I was wondering if you could describe a bit regarding the clinical course of chronic subdural hematomas. Why is this such a serious condition, and how does it affect patients' ADLs and mortality and that sort of thing?
Yeah, I think the one reason it's such a serious and important condition is how common it is. As far as neurosurgeries go, it's one of the most common disease processes that a neurosurgeon sees. There was a recent paper that predicted that there would be 60,000 cases per year by 2030, and that the incidence would be 20 in 100,000 adults. So I think how common it is one reason why people have gotten so excited about this disease process recently. But the course is variable. Some people have a benign course and don't require any particular treatment other than observation, and the hematoma can reabsorb on its own. But more than 30% of the time, the hematoma will require surgical evacuation. In the past, that used to be thought to be due to repeated bleeding events related to a bridging vein tear. That was what I learned in medical school, and even early in my residency, going up until 2015. And then only since then did I start to learn and hear more about this chronic inflammatory process that occurs in some cases of chronic subdural hematoma, in which the hematoma can enlarge on its own without a new bridging vein tear through microbleeding from this neomembrane that forms. That new understanding of the disease process can happen in some patients, and then some patients will have this slow, spontaneous growth, continuous growth of the hematoma that requires some kind of treatment, some kind of surgical evacuation.
Yeah, thank you for heading into kind of what was going to be my next question as well, which was to discuss a bit more the pathophysiology of chronic subdurals, why this might be different than acute subdurals, and then that would be a lead into our discussion regarding MMA embolization.
In anticipation of a recent talk, I was looking through the literature to see what the earliest description of a chronic subdural I could find was. And actually, I found one from Virchow from 1856. I think that's probably the earliest. It's called Das Hämatom Dura Mater. It's in German. I couldn't even find an English translation of this particular article. So Google Translate had to help me out a little bit throughout. But in it, he described a chronic tachymeningitis of the hematoma and described that there's a inflammatory component to this that appears to contribute to its growth and its severity over time. So there have been some great recent articles reviewing what our new understanding of the pathophysiology is. And from those, I've learned that a single bleed can cause an inflammatory state, and that inflammatory state will cause some neoangiogenesis on the underside of the dura. And that will lead to some leakiness in those arteries, those small inflammation-related abnormal arteries. And that can lead to slow progressive growth of the chronic subdural hematoma and intermittent acute subdural on top of the chronic subdurals. And then a enlarging chronic inflammatory membrane can form, causing a feed-forward mechanism that can lead to continuous growth and worsening of the condition. So it's a pretty interesting kind of new understanding of how this works, and better understanding this pathophysiology has led to the idea of blocking off the arteries to the dura and perhaps shifting that balance in favor of reabsorption. I, like everyone else, was skeptical that this played a role in what I'd always understood as a bridging vein tear issue. But there were some angiographic signs that had been published up to then And they were summarized really nicely in an article out of Cornell by Link et al. And I believe Jared Notman was the senior author on that, where they reviewed the angiographic and radiographic findings around a subdural that suggested that there was some leakiness to this membrane and supported that pathophysiology. So one of the findings is that the arteries in the angiogram appear a little bit abnormal. They appear extremely squiggly. That's the most scientific term I can think of to describe it. And then the second thing they talk about is that there's a blush in the dura in the distribution of the artery. So normally when you inject an ECA vessel, you see crisp ECA arteries. But in some cases, when a membrane is present, you'll see an arterial blush in what we now understand to be the membrane. So that's the second finding. And then the third finding is you can actually see the membrane itself opacify sometimes, where you'll see both the convex and the concave components of the hematoma, the part right against the brain and the part right against the dura. And then finally, if you do a CT after an angiogram, you see that there's an increased hyperdensity throughout the entire subdural, as if the contrast has leaked into that space. So with all those findings together and a better understanding of the pathophysiology from some translational and basic science work, it supported the idea of blocking off the arteries as a possible treatment avenue. The question, once you come to that conclusion, is how can we best do that? What's necessary to do that? What's the lowest risk procedure to do that? And it's been really exciting and interesting to see all this develop in front of us over the last few years, and people figure out what the procedure should consist of, how the trial should be run, and then see these trials run to completion.
Yeah, thank you so much for elaborating on all of that. And what were some key findings or some key takeaways from some of the trials that were recently presented? And could this be potentially used for all patients with chronic subdurals moving forward?
Great question. So the trials were similarly designed, and to name them, the three trials that were presented at the International Stroke Conference were the STEM trial, and this was on clinicaltrials.gov. The title is the SQUID trial for the embolization of the Middle Meningeal Artery for the treatment of chronic subdural hematoma, or STEM, and that was sponsored by BALT. Then Embolize, which was sponsored by Medtronic, and that was embolization of the Middle Meningeal Artery with Onyx liquid embolic system for subacute and chronic subdural hematoma. And then the third one that was presented was a Chinese randomized clinical trial called MAGIC MT. Really love that name. And that was managing non-acute subdural hematoma using liquid materials, a Chinese randomized trial of MMA treatment. So all three of those finished at a similar time frame, and they had similar designs. The design structure, without going into the details of each design structure, essentially they had two questions within each study. And the questions were, if a patient undergoes surgery and MMA embolization, is that better than undergoing surgery alone? Or if the patient undergoes medical management and embolization, is that better than undergoing medical management alone? So in both of those types of patients who are managed, does it make sense to also do MMA embolization in addition to that standard of care? So in these trials, and also including the membrane trial, which has finished enrollment and has not yet presented its results, the final endpoint of that trial is a 6-month endpoint, and the final patient was enrolled just before the International Stroke Conference. So that final endpoint will be coming up in 3 to 6 months. So all those trials were basically designed in that it would be determined by the operating team, by the managing team, if that patient's going to undergo a surgery or not. Once that decision is made, then the patient is presented with the study details and then randomized to undergo MMA embolization or not. And then the primary endpoint for the trials often included both a clinical and a radiographic endpoint. And so I'm just going to read the endpoint to make sure I get it right here. And so looking at the STEM endpoint, the primary outcome was you had to have residual or reaccumulation of the subdural hematoma of greater than 1 centimeter, 180 days after the intervention. So 6 months after was the STEM primary outcome, or reoperation or surgical rescue within 6 months, or any new or major disabling stroke, myocardial infarction, or death from any neurologic cause within 6 months. So this one was a combination of a radiographic, a clinical, and then a safety outcome kind of wrapped into that primary outcome. Embolize took a similar approach, and their primary outcome was the rate of hematoma recurrence or progression requiring surgical drainage within 90 days post-treatment. The primary outcome for MAGIC-MT was symptomatic subdural hematoma recurrence or progression rate within 3 months after randomization. So you can see that there's a lot of commonality between the way these studies were designed. Then what did the studies show? So 3 studies presented their results. Each study achieved their primary outcome, showing that the MMA embolization groups experienced that primary outcome less than the non-embolization groups. And in each study, it appeared that the embolization procedure was safe. So to go in a few of the details, the STEM trial showed that the patients who underwent embolization, whether they underwent a surgery or not, they had a 15.2% chance of reaching that primary outcome. And the standard of care patients had a 39.2% chance. The odds ratio there for that outcome was 3.6. And that was significant to a p-value of 0.0001. What was really interesting about the STEM result is that the effect appeared to be stronger in the non-surgical group. There appeared to be an effect in both groups, but the effect in the non-surgical group appeared to be stronger, where the odds ratio in the group undergoing surgery was 2.4, and the odds ratio in the group who was a non-surgical group was 6.1. So perhaps looking at the results of this study, the effect of MMA embolization was partially blunted, but not eliminated by undergoing a surgery. So it maybe makes the case even a little stronger to do MMA embolization in a patient you're trying to medically manage rather than one who needs to undergo surgery. The embolized trial results that were presented showed that the primary outcome occurred in 4.1% of patients who underwent embolization plus surgery and 11.3% in patients who underwent surgery without embolization. So this was a relative risk of 0.36 for a patient needing to undergo some kind of surgical procedure for treatment of their chronic subdural. And that chance was decreased if they underwent embolization by about a factor of 3. And then finally, MAGIC-MT's results were that patients who underwent embolization had a chance at a rate of 7.2% experiencing the primary outcome. And patients who had usual care had a rate of primary outcome of 12.2%. And that was a risk difference of 4.93. And so each of these trials was statistically significant for that primary outcome. And then each of the trials also reported their safety outcomes. And each trial concluded that the device used appeared to be safe overall. I won't dive into all the details there, but I'm really looking forward to seeing the papers and looking into the details of the few safety events that occurred. But I think the concern in the community was this does appear to be a very safe procedure. Is that going to play out in a randomized clinical trial? And it appears that it really has played out. It does appear to be something that can be performed in a very safe manner.
Yeah, thank you for that great summary, Chris. That's great. It really does show that MMA embolization can be helpful in patients with chronic subdurals. Is there any particular unknowns, though, that we still don't know about this therapy? Are there other risks that we should consider in these patients? Because my understanding from my knowledge of those trials is they didn't necessarily enroll everybody who had a chronic subdural, right? Or are there certain patient populations we may not know about with chronic subdurals?
Yeah, absolutely. There's so many remaining questions. One question, for example, is do you need to do a complete deep penetrating embolization, or can you just block off the MMA proximally? And we know that the dura is well vascularized and there are collaterals coming from all of the vessels that supply the dura. So can you place a coil in the proximal MMA embolization? That was not done in these trials, but if you do an embolization and liquid embolic blockage, can it be a point embolization, or does it really need to perfuse? And what's the benefit of perfusing more distally? Do you need to be super selective in each of the vessels? And then another question is it better for you to do a bilateral embolization if you have a unilateral lesion? I know that is something many groups are doing. When you embolize one side and do an angiogram on the other, many angiographers have commented that you can see collateralization coming back to what you've embolized. And so there might be some additional supply. But we were talking about the balance. You're shifting the balance by doing an embolization, shifting the balance towards reabsorption. So do you shift that balance enough by just doing a proximal embolization on one side? That's one question. Another question we've got to answer. And then I think you might have been getting at what groups might benefit or not benefit from this procedure. Patients who are on anticoagulation or antiplatelets and need to get back on those quickly Is there a benefit to performing MMA embolization for those patients? Are you fortified? And can you more safely restart that anticoagulation medication prior to waiting for complete reabsorption of the hematoma, for example? If you've got a patient who's falling regularly and suffering repeated traumatic episodes, should that patient have a lower threshold for being embolized to, quote, fortify that patient? So there are some interesting patient groups where they might be higher risk for having a surgical procedure. And so maybe you have a higher threshold for undergoing a surgical procedure for those patients and a lower threshold for undergoing MMA embolization for those patients. Another benefit of MMA embolization is you can do it under MAC, depending on the patient's level of cooperation. So you may avoid the risk of general anesthesia if you're trying to decide, should I do a surgical procedure to remove this hematoma? Another question is, how do these other medications that we know interact with the subdural hematoma reabsorption rate? How are those impacted, or do they augment the effect or decrease or blunt the effect of embolization, such as statins? There was a randomized clinical trial published in 2018. It was a Chinese randomized clinical trial in JAMA Neurology looking at the impact of statins on the reabsorption rate for chronic subdural hematomas, and patients who were taking atorvastatin 20 milligrams had a more rapid rate of hematoma reabsorption and a lower rate of developing neurologic deficits related to the hematoma. So that may be an anti-inflammatory process. And does that effect still stand in the presence of MMA embolization, or do they work in the same way that they would blunt each other's effects? That's definitely something we might learn from these studies, as patients in these trials were not stratified by taking statins. So it's certainly going to be very interesting looking at all of the subgroup analyses and the larger meta-analyses that come out of these trials in the future.
Thank you. That's good to know, and interesting to kind of think about how some patient populations might really stand to benefit from this procedure. I know you've mentioned, membrane a couple of times, and I know that there's some additional trials that are ongoing. Are you at liberty to discuss any of those and how they might differ at all from the 3 trials that we discussed earlier?
Yeah, absolutely. I'm one of the global PIs of the membrane trial, so I'm passionate about that trial. It got started a little bit later than the other studies, but it finished just a few days before the results were announced. So I thought of that as a great moment to get the full enrollment done before perhaps equipoise was lost in some of the groups, if that were to be the case. The membrane trial is organized similarly to the trials we discussed, except that in all cases, the embolization was performed within 1 week after the surgical resection, and it was performed with a different type of liquid embolic called TrueFill NBCA, which is a glue adhesive rather than a cohesive substance like onyx and squid that was used in the other studies. So it's a slightly different liquid embolic, a slightly different embolization technique. Looking forward to seeing the results of that study, which will probably be announced in late 2024 or early 2025. There are many other trials, by the way. If you look on clinicaltrials.gov, you'll see dozens of trials.
Yeah, thanks, Chris. I think those were most of the questions I had for today. Really appreciate your time and getting on the call today.
Thanks a lot for having me. It's a really exciting space and a lot happening here. Looking forward to seeing all these papers come out and the other trials finishing.
That was Dr. Chris Kellner, cerebrovascular neurosurgeon at Mount Sinai, interviewed by Dr. Sarah Nelson, neurointensivist and neurohospitalist at Tufts Medical Center. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Sarah Nelson, Caitlin White, and me, with help from Michelle Johansson and Jen Hurley. You can subscribe to us so you never miss an episode at myana.org. That's it for ANA Investigates. Next month, we'll have the second episode in this series, Minimally Invasive Techniques in Spontaneous Intracerebral Hemorrhage.